We have to manage the patient very well because this is the third leading cause of death, and most of the patients of COPD will have a greater mortality and morbidity if they are not treated well. The management strategy of COPD is based on the assessment of symptoms and the history of exacerbation. The management strategies include the pharmacological and the non-pharmacological interventions. What is the goal for the treatment of stable COPD? That we want to reduce the symptoms. So, release the symptoms, improve the exercise tolerance, and improve the health status of the patient. And we want to reduce the risk of the disease. So, prevent the disease progression, prevent and treat the exacerbation, and reduce the mortality. That should be the goal of the management of COPD. First of all, identify and reduce the risk factors and try to reduce those risk factors. So, by smoking cessations should be actively pursued in all the patients of COPD, efficient ventilation, non-polluting cooking stove, and the similar intervention should be recommended. Clinician should advise the patient to avoid continued exposure to potential irritants if possible. So that should be the important how to protect your patient from the pollution, smoking. This should be the goal of the physician. Now we have very good drugs are available. Just a moment. As we have seen, now how to treat a patient of group E. We have come if the exacerbations are more than 2 or any exacerbation, if it is more than 1 leading to the hospitalization, that is group E. We use the LABA and the LAMA. A long-acting beta-2 agonist and a long-acting muscarinic agent is required for the treatment of group E patient. If the eosinophil count is more than 300, then we use the inhaled corticosteroid. In group 1, when the exacerbations are very less severe, we use a bronchodilator. We will use a LAMA here, and in group B, a combination of LABA and the LAMA. When the MMRC score is more than 2 or the CAT score is more than 10, group B patient will be requiring a LABA and a LAMA. We have a very good quality of bronchodilators are available, which is very important in the symptomatic management of the patient. Patient will come to you, he will be having a air hunger. If you give a good inhaler, either a MDI or the DPI or the nebulization, there will be a dramatic response in the patient symptoms. So patient will say that डॉक्टर साहब आप तो भगवान हो मेरा एकदम सांस आने लग गया. So you have to choose according to the need of the patient. If the patient is very sick, then you will choose a nebulization. If the patient is having a good FEV1, you can use a dry powder inhaler. If the patient is having a low FEV1, then we will go for the MDI. We will try to improve the emptying of the lungs, reduce the dynamic hyperinflation, and improve the exercise performance. 3 major classes of bronchodilators are there: beta-2 agonists, a short-acting salbutamol or levosalbutamol or terbutaline, long-acting such as salmeterol, formoterol, and the vilanterol. These are the long-acting beta-2 agonists. So, but my choice that formoterol will have a quicker action and the action is for 12 hours. So try to use the agent that is having a quicker action, safe and have a long duration. So use a formoterol in patient of COPD. About the anticholinergic agents, earlier we used to treat the patient with the ipratropium, that is a short acting. Now with the better drugs available, we can go for a tiotropium, glycopyrronium, and the midoclinidium. These are the LAMA. And a theophylline we have been using for many years, darifylline, acibrophylline, and methylxanthine. So these are weak bronchodilator, but they have a anti-inflammatory properties is there. So a combination of SABA or SAMA can be used, but better to use a LABA and a LAMA in the patient of COPD. If the eosinophil is more than 300, better to use a inhaled corticosteroid. Inhaled corticosteroid combination therapy is more effective and it improves the lung function and the health status and reduces the exacerbation as compared to the LABA and the ICS. So a triple combination of LABA, LAMA and the ICS should be used in the patient of group E patient. Now, sometimes we use a oral glucocorticosteroid. They are used for treating acute exacerbations in the patient of who are in the hospital. The long-term uses have various side effects like steroid myopathy, a decreased functionality, a respiratory failure is very common in the severe COPD. Phosphodiesterase inhibitors such as roflumilast reduce the inflammation by inhibition of breakdown of intracellular CMP used in the patient of chronic bronchitis, severe to very severe COPD, and the history of exacerbation. But these roflumilast has a very limited role in the patient of chronic bronchitis where there is a recurrent exacerbation and sometimes the chances of tolerance is always there. So better to use a LABA, LAMA, ICS, oral glucosteroids can be used, xanthines can be used, a proper antibiotic should be used. A long-term azithromycin 250 milligram per day or the 500 milligram 5 times a week for 1 year reduces the risk of the exacerbations. We have N-acetylcysteine is there, which acts as a mucolytic and the antioxidant. These has a very good role in the patient of COPD. In my practice, I use a combination of N-acetylcysteine and ambroxol. The chances of clearance of the sputum is very high. With these two mucolytic and antioxidant agents, we can use a simvastatin leukotriene modifiers can be used to reduce the inflammation. What is the role of biologicals in the COPD? We have anti-IL, that is anti-interleukin 5 monoclonal antibodies, mepolizumab, can be used in the patient of COPD, and in those patients there is a peripheral blood eosinophilia in spite of the high doses of the ICS. Then we can use a interleukin 5 receptor alpha antibody bernalizumab. We can use this patient, but this increases the cost of the treatment and it is not easily available everywhere. Other pharmacological treatment such as alpha-1 antitrypsin can be supplemented when we have the titer that the disease is due to the deficiency of alpha-1 antitrypsin. We can use the antitussive, but it is better to avoid this antitussives. Only in the irritating cough, we can use the antitussives. The vasodilators in patients with pulmonary hypertension to reduce the pulmonary arterial pressure, such as tadalafil, ambrisentan, and the bosentan, can be used to reduce the pulmonary arterial hypertension. Mucus clearance by LAMA triple therapy with mucolytics and nebulization with hypertonic saline is always better. The follow-up pharmacological management should be guided by the principles of review the symptoms and the exacerbation of patient, assess inhaler technique. Whenever you give the inhaler to the patient, you should always check that the patient is taking proper inhalation therapy, he is adhering to the therapy, and we should also try the non-pharmacological approaches should be also tried.